Thank you everybody for coming. I apologize for my voice. I think I lost it at the craps table last night. Hopefully not with too much else. So today we're going to talk about working with advanced practice providers. This talk is sponsored by the interest group that is for medical directors of advanced practice providers, of which I chair. My name is Liz Temin. I work at Mass General Hospital. We also have Tala Elia, who is the Associate Chief at Bay State Health Center, Medical Center, and is the Medical Director for the APP program there, which also houses an APP residency. And Sharon Chekijian, who is the Medical Director for the APP program, including also an APP residency at Yale. All right, so we'll start.
So we're going to cover a few things today. We're going to go through some concerns, some myths that are out there about working with advanced practice providers and address some of those true, false, fact, or fiction, or maybe we don't know. So the first thing I'm going to address is, I assume you're all here because you have some interest in this. You work with APPs, you supervise APPs. Well, the first myth is, well, this won't affect me because I don't work with APPs. While most people in this room, that probably doesn't apply. I know we have residents going to programs where they currently don't have APs in the emergency department. And can they really anticipate that this is going to be the case, that they're not going to have to be knowledgeable about these issues? Well, if we look at current trends, there's nurse practitioners and physician assistants working in every state in the country. The darker green is where there's higher concentrations, versus lighter green, lower concentrations. This is nurse practitioners, here's physician assistants. You can see that trends are similar. There's some higher concentrations on the coast, but overall there's nurse practitioners and PAs in every state in the country. In this setting, there's also a projected emergency medicine physician shortage. The AAMC projects somewhere around 20 or 30,000 physician shortages anticipated by 2030. A current analysis of the current workforce, using Medicare data, says that throughout the country, on the current state, there's 60,000 emergency medicine clinicians. Now, this includes board-certified emergency medicine physicians, physicians trained in other specialties but are currently working in emergency departments, and advanced practice providers working in emergency departments. Of that 60,000 workforce, only a little less than 2/3 of it are board-certified emergency medicine physicians. 24% of that workforce is currently APPs. There's some divide versus urban and rural. There's some of us who work in urban areas, big cities, don't feel the shortage, but there is a higher concentration of emergency medicine physicians in urban areas and a dearth in rural areas. There's 27% of counties in the United States that have no board-certified emergency medicine physicians. At the same time, the projected growth over the next 2 decades show that there's only going to be a growth about 1.1% annually of physicians, while physician assistants are growing at a rate of a little over 4%, and nurse practitioners even more at 6.8% annually from 2016 to 2030. This is by the AAMC. Where are all these providers working? Well, in terms of at least physician assistants, we know that many of them go into surgical or primary care fields, with those accounting for 1/4 of the workforce each. But emergency medicine isn't that far off. We're about 9%, the 4th most popular field for physician assistants at least. In all, 80% of emergency departments employ advanced practice providers. So while some people may not work in a setting where they're currently working with advanced practice providers, there is an upcoming emergency medicine shortage for the AMC and a growing workforce of advanced practice providers. So regardless of how people feel that shortage should be filled, the reality is currently there's a fair amount of emergency departments with APPs working in them. Are all APPs the same? You know, you're working in the emergency department, you're supervising APP, they might be a new grad, they might have a little bit of experience, they might be a PA, they might be a nurse practitioner. What do you know about their education and their experience to be able to adequately supervise them? We know a lot about medical students and residents because most of us were medical students and residents. We know the regulating body, and we know what goes into the education and what comes out. For NPs and PAs, for many of us, that's a little bit of a black box. And I'm going to try to unravel that black box a little bit so we know what we're doing. So there's a lot of terms out there, APRN, NP, FNP, ACN, and it's hard to know what to make of all those terms and what means what. So APRN is over umbrella that encompasses nurse midwives, nurse anesthetists, and nurse practitioners. And that's what we're talking about when we're talking about emergency medicine. We're talking about nurse practitioners. So once someone has their role in their education, they then focus on a population focus. And for emergency medicine, we're mostly talking, the vast majority are family nurse practitioners, though there are a small minority that are adult nurse practitioners. So family encompasses birth to death, the whole spectrum of life in terms of age. And so that's why a lot of nurse practitioners in the emergency department are family nurse practitioners. Adult nurse practitioners often specialize in acute care. However, they can only see ages 12 and up. So there's a lot of emergency departments that won't hire acute care adult nurse practitioners, and the vast majority are family nurse practitioners. Now, family is focused it was designed for primary care. Most of the rotations are outpatient settings, and some programs don't allow emergency medicine rotations at all. There is a certification that we'll touch on later that you can get through after or concurrently with family nurse practitioner. That's an emergency medicine specific certification. So what are the degrees? So everyone starts with the Bachelor of Science in Nursing and then can proceed to a Master's of Science and has a choice to go to a doctorate, or there's some programs that go directly to a doctorate. The Master of Science requires 500 to 600 clinical hours, where the doctorate's 1,000. And right now, the Master of Science is the entry-level degree for clinical practice, but there are some organizations that are pushing for the doctorate degree to be the entry-level degree, and that's a little controversial. PA degrees are a little more straightforward. It's a master's. Years ago, there used to be a bachelor's degree. That's been phased out. There are some programs that combine the bachelor and master's as a combined program. You apply straight out of high school and get accepted into a 6-year program, but there's that small number. And there are some programs that are now introducing a doctorate of medical sciences for physician assistants, though those programs are small and new. So what does it take to get into these programs? Who's applying? Who's getting in? So when we're talking about advanced practice providers, a lot of people talk about experience that they bring to the table before school. So a lot of NP master's programs do require a minimum of 1 to 2 years of clinical bedside experience. But there are some direct entry programs that exist. And these are programs where someone gets their bachelor's degree and then proceeds straight into a master's or even a doctorate degree without having any bedside nursing experience. PA programs most require a fair amount of clinical experience prior to application, but there is a range. They range from some just say experiences recommended or preferred. Others require 2,000 hours of experience. There are only 3 programs that don't require healthcare experience at all. But when you look at the applicants that are actually admitted into PA school, they have an average about 3,500 hours of healthcare experience if you're looking at applicants who actually get in. And let's look at the competitiveness of these schools. So these are comparing NP programs, PAs, and U.S. medical schools. So of all applicants, the PA and medical schools are a little easier to quantify because they have a central repository for applications, and so they report that data out. U.S. med school admit 4.6% of their applicants, where PA programs admit 34%. Again, NP schools, they apply directly to the program, so there's no central repository of that data. U.S. News and World Report took a look at this, and they took the 10 most highly ranked NP programs. They had a combined acceptance rate of 24%, but of the 400 programs, there were another 17 at least that had acceptance rates of 100%. This is looking at the clinical contact hours, because when we're trying to compare things, how can we sort of look comparably? And this is looking at actual patient care hours in the degree. So we have nurse practitioner hours and this is a minimum required of 500 hours for the master's. Physician assistants require a minimum of 2,000 hours. Medical students, and there's medical school and residency don't have a minimum required, but the AAMC reports the average number of weeks of clinical contact. And based on a 60-hour work week, a medical student, your intern when they hit the door on day 1 has 5,000 hours of clinical experience, where a graduate of a 3-year program has 13,500 hours. So how do people how are people prepared? How well are people prepared coming straight out of these programs as a new grad? There's not a lot of data out there. This is a survey looking at self-perception of how prepared NP grads felt. They administered this survey at several national meetings, and they asked nurse practitioners that both had years of experience as well as new grads. And overall, a little more than half felt that they were only somewhat or minimally prepared, where only about 10% felt that they were very well prepared coming straight out of school. What about EM specialty certification? There's all sorts of fields that APPs work. What about emergency medicine and what's out there for additional training? So the physician assistants have something called a certificate of added qualifications. It's an optional certificate that PAs can get. They've already have taken their PANCE exam, which is the board certification exam, and then with an additional 3 hours of EM experience, and this has to be over a span of 6 years, additional CME, and then a procedural requirement, they can sit for a specialty exam and qualify for their certificate. Nurse practitioners have a relatively new certification that's an option as well. It's a little more variable in what qualifies people to sit for this exam. There's a clinical track option, sort of similar to the PA option, where you need 2,000 hours over 5 years, again, a CME and a procedural requirement. And then there's two other options. The third one is a fellowship, so an EM residency or fellowship. And the second one is an academic program, and this is that certification on top or concurrently to the F&P that I talked about. There's about 12 programs out there that offer this right now, and they range, there's some variability there as well, and they range from about 200 to 600 hours of EM experience in those programs. So where does that get us? Well, know what's inside the back box. When you're supervising a PA or an NP, there can be quite a bit of variation, especially in NP training. There's a broad variation in practice, so you really need to probe deep to know what level of supervision you need to provide.
Perfect. So how many APPs do we actually have in the room? I see Fred back there. So just one. So one nurse practitioner and one PA. This talk was actually framed by some of the things we were seeing on EM Docs on the Facebook page. And so one of the myths that we've really seen quite a lot of is that APPs work autonomously and that people are going to be put out of work. And so we wanted to really delve into whether or not that was true. So where does NP autonomy stand? How do NPs view their own practice? Currently, you can really break down autonomy into full practice autonomy, reduced practice autonomy, and restricted practice. And this really varies by state. The NP group is lobbying very hard, really in every state. There's sort of a battlefield right now of trying to define practice. So this is a current map right now. 23 states plus DC have actual full practice autonomy. You can see in yellow, this is reduced practice, and in red, these are very restrictive states, including California. So you can imagine in places where there's restricted practice, it's much harder as an NP to get a job. And vice versa, in states where they have full practice autonomy, it's a lot harder for PAs to get jobs. So how do NPs view their own practice? This was a statement from the AANP from 2006 that's currently up to date, and their position statement. And I have a few position statements that we're going to go through, so it's a little bit on the dry side, but I think really interesting. So nurse practitioners are licensed independent practitioners who provide primary and/or specialty nursing and medical care in ambulatory, acute, and long-term settings. And then they go on to say, as a licensed independent practitioner, the NP participates as a team leader and member in the provision of health and medical care, interacting with professional colleagues to provide comprehensive care. So how does this differ from how the PA group tends to view themselves? PAs, as everybody knows, really developed on the battlefield as medics, and they worked in conjunction, hand in hand with MDs. And so there's a much more collaborative relationship between PAs and NPs. However, the AAPA has made a statement that there is an inevitable push towards autonomy, but it's not a concerted lobby effort at this point. And that effort is really, or the push is really coming because the NP groups are pushing so hard for independent practice in every state. And the PAs are starting to feel that in order to be competitive, they also need to pursue more autonomy. There is no place other than the Netherlands that I could find where PAs are given an independent license currently. But as I said before, the NP groups are really paving the way with their legislative efforts. So PA practice autonomy, according to the AAPA, there's sort of a shift in language right now from collaborating physician to collaborating physician from supervising physician, and that's really determined at a state level. Oh. Do you have a power cord? All right, sorry. While they're fixing that. So there was an interesting study that actually came out from AAPA that said that those in practice longer actually spend very little time talking to their supervising or collaborating physician, depending on what the state statute says. In fact, as they get further along in their practice, maybe somewhere around 8 or 10 years, and they're more confident, they may only consult the physician that they're working with about 10% of the time. Now, this applies to primary care and specialty care. Both were surveyed. And this really allows for maximum flexibility in terms of being able to see patients, but it minimizes the liability to the APP themselves or to the PA. So some of those hot issues, as I said before, are really moving away from supervising physician to collaborating physician, or even eliminating the need to have a supervising physician. But when PAs were surveyed, about 96% of them still wanted to be part of a team. They did not want autonomous practice per se. Thank you. Sure. So I'm just going to wait for that to reboot because I can't remember all the position statements off the top of my head. But
Sharon?
Mm-hmm. Oh, thank you. See if I can read it with my little eyes. Yeah. So what does the AMA say about this? With regard to physician assistants, specifically, the AMA policy states that physician assistants should be authorized to provide patient care and services only so long as the physician assistant is functioning under the direction and supervision of a physician or group of physicians. AMA opposes legislation or proposed regulations authorizing physician assistants to make independent medical judgment regarding such decisions as drug of choice for an individual patient. They also address regulation of PAs and in particular advocate maintaining the authority of medical licensing and regulatory boards. So this is another area where PAs are really advocating for oversight of the regulatory boards only by other PAs and not by MDs, as has been done to date. So this is a little controversial. So, primary care and this filling the shortage in primary care is very different from specialty care, and I think all of us here can say that we believe very strongly that we provide specialized service, that this is a specialty that we fought very hard for, and that we're not going to endanger our patients or our own practice style because of legislative efforts to develop autonomous practice in emergency medicine. So where are the position statements really for emergency medicine at this point? ASEP has come out with a statement that PAs and APRNs do not replace the medical expertise and patient care provided by emergency physicians, not surprising, but that PAs and APRNs working in the ED should have to acquire specific experience or specialty training in emergency care and should receive continuing ed in providing emergency care. And because of this, we've seen the development of the CAQ and also the ENP certification that Tala had referred to before. We're also seeing the really quick development of residency programs, and as you can see, 2 out of the 3 of us have residency programs where we believe that we're training people that are dedicated to the specialty to the best of our abilities, and we're using all of the framework of our academic institutions in order to do that fairly easily and comparably to our medical residents, although always in a shorter amount of time, unfortunately. So this past year, AAEM came out with a statement that was a bit more on the inflammatory side, and Fred Wu, who's in the audience, actually wrote a very nice rebuttal to the statement. Their statement says that the AAEM believes that the emergency department patient should have timely and unencumbered access to the most appropriate care led by a board-certified EM physician. We do not support the independent practice of APPs and other non-physician clinicians. And they go on to say that the APP should not replace an emergency physician, and then they also weigh in on charting and supervision, saying that the billing and charting should reflect the involvement of the physician in the emergency visit, and if the physician's name is used for billing purposes, then they must have added value to the patient visit. And I think in academic emergency medicine, we perhaps have a little bit more time to supervise than in other places where people are feeling the pressure, and you can see this all the time on EM docs and in non-academic institutions. Patients are seen in other areas ectopic to where the physician is practicing, and perhaps not even in synchrony when they're in the emergency department, and people are having to sign charts on patients that they're not actively supervising. So that's an important point, and definitely requires underlining and a lot of introspection on our part. Do we want to allow that to happen? SIMPA has come up with a statement that says, as PAs, we wholeheartedly agree that physicians, by virtue of educational process and training and specialty certification, are the most highly educated and trained clinicians in the healthcare system. As clinicians who have the patient's greatest interest at heart, PAs by law, statute, and professional ethics attempt to avoid any confusion and risk reputation of their roles. And this goes to the heart of these doctorate degrees that people are now obtaining. AMA had come up with a statement saying that people should not misrepresent themselves as doctors unless they're an MD in a clinical setting. And that has been occurring more and more. Moreover, they go on to say PAs value being members of a team that provides excellent care for patients, and that's clearly where our emphasis should be, and believe that the team approach serves the patients more completely. So where does SAEM play into all this? And currently there's a task force at ASAP that has representation from SAEM, but there is no clear policy statement to date, and so that's something that we'll be working on going forward. On the nursing side of things, we have people that believe very strongly on the PA side in emergency training and advanced training in our specialty. On the nursing side, there is a group called Emergency Nurse Practitioners. They are underneath the AANP, or the American Academy of Nurse Practitioners, and they have delineated the advanced certification. That was just done in 2016, so only 2 years ago. And it's really unclear to us at this point if people are being encouraged, compensated, or advanced based on whether or not they're receiving that certification or initiating that certification. That group has put out a statement saying advanced practice registered nurses have a broad depth of knowledge and expertise in their specialty and can manage complex clinical and systems issues. Nurses in advanced clinical practice provide comprehensive health assessments and demonstrate a high level of autonomy and expert skill in the diagnosis and treatment of many complex problems. In the emergency setting, APRNs are uniquely prepared to develop and apply theory, conduct research, educate healthcare providers and consumers, and develop standards of practice that contribute to the optimum patient outcomes. So I'm just going to see if I can get my slides up here.
It's not advancing.
Yeah, now I'm going through it. So next myth that we have are, do APPs save money? So where does that idea come from, and how does billing really work? So most people might know, or maybe you don't know, that Medicare actually will pay for the services of a PA or an APRN up to 85% of the normal billing that they would reimburse for an MD. And the way that this is billed is different between outpatient settings where there's incident to billing that's performed, or inpatient or hospitalist billing, and the emergency department is included with that pot. So in the hospital, we're allowed to do what's called hospital-based billing with a split or shared visit. And if a doctor participates in that visit and examines the patient and adds to their diagnosis and care, then they are allowed to actually bill under the doctor's NPI number and not under the PA's number at 100% of what they would normally get reimbursed for. Whether or not we get that, I don't know. So in order to do that, you really have to set the bar high. And this really underlines what we were talking about before, which is that there is a lot of pressure to get that incremental billing of 15% without actually providing the patient with an increase in thought process, medical decision making, and to add an unnecessary 15% onto the bill. So we have to be really careful when we are co-signing charts and saying that we've examined somebody and that we believe that we're essential in their care, that we really believe that. This is what I was just saying. The flip side is you really have to believe and reflect the value that you've added in care in your documentation. Commercial insurance is very variable. In most cases, they follow the lead of Medicare currently, but in general, all of them do reimburse the care provided by PAs and APRNs at this point in time. So do they save money? There was a recent national survey of Medicare beneficiaries that showed that in primary care, at least, the NPs were providing care that was significantly lower. The cost of care was significantly lower than which was provided by the MDs. But there's a real big problem in emergency medicine and with the shared visit model in that there's no transparency. So we don't really know how much of that visit can be attributed to the MD, how much can be attributed to the PA or APRN. So the value of their work and their expenses that they may be adding is sometimes buried within that shared visit. So we really need to tease that out going forward. And if currently people are saving money, we also have to keep in mind that there's not only a race to actually unfettered practice, but there's also a race for reimbursement parity, especially within the NP lobby group. So there are many efforts to kind of make that incremental difference less and less and have NPs paid exactly the same as the doctors are paid. So that savings would go away if that's the case. In addition to that, there's also a real push towards salary parity and a thought that if some people are doing the same work as the MDs, that they should be paid along the same lines. So there's definitely a lot of controversy there. Other areas that could be brought up and discussed in great detail are not only independent licensure, but limitations on prescriptive authority or lifting of those, self-governance, so this drive towards self-government, and the idea that we should really think about in specialty care, does the unfettered practice really apply to specialty care or should it only apply to primary care? And I think we need to weigh in really soon. And as I highlighted before, there is a friction right now between the NP and the PA groups because they are not, as Tala had talked about, not really comparable in terms of the education that they're coming in with. And they really want to be competitive in the same playing field. So that's causing a lot of controversy between the two groups as well. So Liz is going to come and talk about insurance and risk.
Thank you. All right. So let's talk a little bit about numbers. So this is a survey that was done by SEMPA and ASEP a couple of years ago, looking at how often there is on-site physician supervision by an emergency medicine attending. So I have a pointer? No. So if you look down at the bottom at 100%, so how many times at 100%, so 75% of the time every shift, there is an attending physician on site that is available for an APP to consult if they need it. It doesn't say that they are seeing every patient, but it says that they're on site and available. If you look just below that, 6% of the time, 5.93, they are never, ever on site. Okay? And then there's some variability as well. And then this is a study that just came out last year. This was a survey that ASEP performed of the ASEP Council. And you can see so the first column is kind of acuity level. The second column is what percent of EDs allow their APPs to see these patients. So you can see the lower acuity, the ESI 4 and 5s and such, 95% of those EDs will have APPs seeing those. And when you get up to ESI level 1s, about a third of the EDs allow their APPs to see those. Now, but the next column is one that I find very concerning, is that how often are there real-time presentations for every single patient in that group? So when you're down at the low acuity patients, about a quarter of the time, every patient is presented to an attending. But as you get up to an ESI level 1, still only 50% of the time, a patient, every single patient is presented to an attending. So that means 50% of the time, that is not necessarily the case. And that breaks down into whether they can do it at the APP's discretion, or whether the MD has to review the chart afterwards and sign it, which is, again, as Sharon said, something very controversial. Or in the VAR column, there's even 9% of the time the supervising physician had no idea about this patient at all. And so I find these numbers worrisome. And then what is the requirement for co-signing the chart as a physician? There are 3 factors that determine whether a PA's chart needs to be co-signed. And so that is state law or hospital bylaws or regulations or third-party payers. Now, Medicare, which is the largest, doesn't require that a PA chart has to be co-signed by a physician, but they will acquiesce to other requirements, and state law is probably the most stringent. Now, what about outcome? Okay, so there is, so unfortunately, there is very little data looking at clinical outcome. It is very hard to tease out care that was given by an APP versus a physician because their name is often both on the chart, and so it really takes extensive chart review to determine that. So there are not a lot of studies, and of the studies that are out there, there is some variation. So this is a study on pediatric patients that was done in 2017, and it looked at patients who are seen either by an emergency physician alone, by a PA alone, or or both. And what they found is that looking at 72-hour returns, the management across those groups were similar. Now, there's some controversy whether 72-hour returns actually means anything in terms of clinical care, but it is what we have. On the flip side, this is an older study from 2010, but it's one of the studies that I think is really, really well done, looking at adult asthma patients. And what they found is that unsupervised APPs, or APPs that saw a patient without direct supervision of an attending physician, were less likely to administer beta agonists within 15 minutes of arrival. They were less likely to prescribe systemic steroids, and they were more likely to give antibiotics upon discharge. But what they did find is that supervised APPs provided similar care to physicians. So, as I said, there's just great variation and not a lot of good data on outcomes. And what about social media? So, if you're young and do that, which I am not, then you'll find that there is a lot of talk going on in the social media sphere at the moment. Some of it from the vitriolic to the incredibly supportive and everywhere in between. But what I find interesting is that you get cases like this where even though the state requires that an APP would have an EM physician there, the hospitals may not be acquiescing and doing what they want, usually for financial reasons. So there's a lot of information that can be got out there if you can get through a lot of the vitriol. So what about our liability? All right, so this is, so CRICO is the malpractice insurer for Harvard, and it has built this national database. It's a benchmarking system of over 400,000 cases, and this runs from 2007 to 2016, and these are cases that they were willing to share with me. So what we found is that overall, in those 10 years, APPs were actually named in a very small percentage of overall cases. This is not just EM, this is overall. So physicians were named in 77%, PAs in 0.8, and MPs in 0.4. This doesn't equal 100 because I didn't add all the other practitioners, nurses and RTs and so on. I've just limited it to us. But I will say that in 2016, overall there were about 1.1 million practicing physicians in this country, not just EM, as I said, kind of overall. And there were 115,000 practicing PAs, so 10 to 1 ratio. So you wouldn't expect the numbers to be equal, but you might expect them to be. This is still a 100 to 1 versus a 10 to 1 ratio, but it's still not quite as extreme as these numbers lead you to believe. That was also the data in 2016, and as you saw from the beginning, the number of APPs, or the number of PAs in this case, have increased over the years, and in 2007, when this data started being collected, that ratio may have been very different. So just something to take with a grain of salt. There was also a nice study in 2016 that looked at malpractice payments reports per 1,000 physicians, PAs and NPs, and again, the ratio was different. So things look favorable for the APPs, but I would say the numbers they're extenuating circumstances that need to be taken into account. Now, what happens when an APP is named? So as you can see in the lighter blue, APPs are named alone in only about a quarter of cases. And in the other 3/4 of cases, either the institution or a physician or both were named with them. So if you put together kind of where the supervising physician was named, it's 67% of cases that APPs are named in, a supervising physician is also. And we don't, unfortunately, have the data to know, are those cases where the MD actually saw the patient or not? CRICO doesn't break it down that way, unfortunately, but still, those numbers show that the MDs are involved as well. So where are the errors occurring? And in comparing the groups, it's actually pretty consistent that both the APPs and the MDs, the issue really is clinical judgment, and that's where the highest number of malpractice cases come through. And that's pretty consistent, as I said, across the groups. So what about me? What about if I write an attestation, right? There are all kinds of attestations that people say. I was there, I saw the patient, I interviewed them, I discussed, but I didn't see the patient, I was available, but nobody asked me about it, and I was nowhere near the patient. And is that helpful? Well, the short answer, yes, is no. Again, CRICO doesn't break down that information in a way that is useful for us. But what I can say from talking to their legal counsel and what we can say from talking to the legal counsel at our hospitals, this is probably doesn't make any difference. It's not helpful. If the lawyers are going to name you, they are regardless because your name is on the chart. And I don't know the outcome data with it, but in terms of being named, it's probably not helpful. And this is really used more for billing. As Sharon said, you really have to show that you have provided some clinical care that was necessary for the care of that patient, and that's really what these attestations should be used for. So what if I only see patients in low acuity areas, right? How bad can it be in fast track or urgent care? You know, that's not so bad, right? So this is an actual case that settled from CRICO. So this was a 60-year-old female with an extensive past medical history. She called her doctor's office. She was moving furniture. She felt pain in her right arm. So she was sent to an urgent care. Her vitals were stable. She was maybe borderline tachycardic. She had some pain in the right upper extremity, but she had no paresthesias, no color change, no tenderness at the radial head. Neuro was intact. She didn't report any chest pain or shortness of breath. The PA got an x-ray. It was normal. She was put in a sling and sent home. There was an MD available for that PA if they wanted, but the PA didn't feel it was necessary to discuss the case. So later that evening, the pain started radiating across the chest. She went to an ED and was found to be having an acute MI. This case settled. So these are, low acuity areas where you're seeing patients that most of the time have musculoskeletal or low acuity problems. The problem is if you're not trained to look for high acuity problems, you're going to miss it, right? So when we talk to our residents, we say, what is the differential? If you don't think of it, you're not going to look for it and you're not going to find it and you're going to miss it. And that's the same. So the workup here looks reasonable, but maybe you would have said, you know, they have all this odd past medical history, maybe I should just get an EKG. Or maybe there's no tenderness when I move the arm, or the patient looks a little pale. But if you don't think to look for the high acuity, there's no way you'll ever find it. So having someone trained only in low acuity care, I think, is a potential for a miss. And the data actually supports that. So if you look at cases where the outcome was a high clinical severity injury, so this is either death, permanent grave, permanent major, or permanent significant injury, the ratio of high to medium and low is actually pretty consistent along PAs and NPs, PAs, and MDs. But as we saw earlier, the APPs are seeing much more low acuity patients. And so they're seeing lower acuity patients, but their chance of missing high acuity injury is pretty close to the same. So that is something to worry about. And then this is the key, the path forward. We have no idea where we're going. As you've seen for this, it's really kind of the Wild West, as Sharon says. There is great variability in training, in education, in supervision, in how people are integrated into the departments, and that variability leads to potential downfall. And so I liken this to medical residency education in the 80s. So if you remember in the 80s, for those of us who are old, as I said, you know, residents worked, they took call without an attending supervision, attending in-house. And they worked long hours and they had no supervision. And it took some sentinel cases to make a difference. So in, I think it was 85, Libby Zion case, right? There was a patient who died of serotonin syndrome because the resident gave them medication that interacted with their antidepressant. And even as late as the early 90s, in 94, Betsy Lehman died of an overdose of chemotherapy because the dose that was given was too high because there was no supervision. And it took these big cases to create change and to create the work hours that we now have and the requirement that there be supervising physicians. And I don't want us to get to the case where we have similar sentinel cases with APPs because they're not being properly supervised for their level of education and training. And so I think that this is something that, as supervising physicians, we need to work with the APP leadership to come up together with requirements for what we consider appropriate post-scholastic education to make sure that people are competent and providing care that is safe for them and safe for us as supervising physicians, and then most importantly, safe for the patients. So ensuring that the APPs that we hire are properly trained, licensed, and qualified, and that there is proper ongoing supervision. And so I just want to say thank you to the patient safety director at CRICO, who was willing to share a lot of this data with me. So I think we have a little time for questions, if there are any. I'm going to bring the mic. Yeah.
What's your sense of what's your sense of how they're going to take responsibility for liability? It seems like they want, you know, all the good stuff and assume all the independence, liability, responsibility.
Yeah, it's a great question, and I don't know. Sharon, do you have any insight into that?
I don't know. I mean, I think we're all a little bit more familiar with the PA group and the PA leadership, and SEMPA has very strong and very appropriate recommendations for postgraduate training, for specialty training, and I think we really need to explore this with our nursing counterparts that are doing the ENP certification and working on those guidelines. And by and large, they've been quite independent and quite aggressive in their lobbying efforts. And as we were speaking with Fred earlier, and we all came to the conclusion that now is the time to speak up if we think things are wrong. So we feel very strongly that this is the time to mold the future. Any other questions?
I'm just curious that if there's anybody planning to or organizing research on this, because while I feel this is a valuable resource to us throughout medicine, much less in the emergency departments, because in a lot of places we're drowning, I think it's necessary to do studies to figure out how is it best to use them. I've had a PA that basically was literally a physician extender, where I would see the patient, do the initial orders, the APP would then go back, do the reevaluation, check the labs, and affect the disposition, which is usually fairly straightforward, or come back to me. That way I could just keep seeing patients. I'm just keep going forward. Makes me more efficient not to have to double back in 2 or 3 hours to see a patient, as opposed to I'll see a patient, you see a patient, call me if you need me, or plug them in the schedule like they were a doctor. And it seems like a lot of places have gone to plug them in the schedule like they were a doctor, and they're not. So I would encourage, if there's any young NP or PAs and docs, that this would be a great study to do in parallel, which one of these models or other models would actually make them more efficient while also protecting patients. And I think actually protecting patients while also being efficient.
Yeah, and again, that gets back to what we talked about before about trying to separate out the metrics so we can actually attribute speed, quality of care, 72-hour returns to the actual APP that's seeing the patients, and not only back to the doctor. Mm-hmm. Correct, and a little plug for Fred for tomorrow, because I think he's reviewing a lot of data from CMS. Is that right? CDC data regarding utilization and quality. So tomorrow at what time? Today, that's right, 4:06? 4 o'clock, we'll say 4 o'clock. 4 o'clock. He projects.
Full disclosure, I used to be litigator, number 2. And number 3, although I had nothing to do with the AA state, I'm the past chair of the legal committee for AA. And use the word inflammatory when you talk about the state. And I think the only reason that statement is inflammatory is because it's a discussion that we are very uncomfortable having in medicine. Because we're talking about our colleagues. But when you look at the facts and you look at the level of training, the numbers that were put up there, there's a stark contrast between the level of training between a physician and the APPs. However, in the media and on television now, there's an equivocation between being a doctor, a nurse practitioner, and a PA, as though we are all the same. And so I think most physicians in the country, if they actually read, nursing physicians, actually read that statement, will probably agree with the statements that are made in that. If you're trying to separate it out from the discomfort we have of saying things like that right next to the people we consider friends that are also PAs. So I don't consider it inflammatory other than somebody saying, we're going to take the bullet to say what people aren't going to say. Having said that, I started an APP program with Duke before I came to Yale. And my experience, anecdotally, is, especially right out of school, they are not anywhere near prepared to practice. They are not. And even the ones that are experienced generally aren't going to be as efficient. When I say efficient, I come from the community, I mean how many patients are seeing it out. They aren't anywhere near the number of patients per hour. So there are stark differences that need to be realized. As a litigator, if I were to take my case, and I was a lawyer in practice before I became a doctor, and I saw a PA make a decision or an NP make a decision early on in the career that thought that out, I would be able to drive a bus, through that argument and really make a cohesive argument to a jury that this was something that shouldn't have been practicing. And now, having said that, the program we have at Yale, that's mainly my experience. Duke Raleigh, they were all great. I love working with them, but there are stark differences. What I'm worried about in the future is there is this equivocation in the public or commercials saying choose NPs. I don't know if you've seen that on TV. They're much better body than we are, and there's this discomfort to in any way say something. You've actually proved that they have the impression to meeting our colleagues that we need to make in order to make sure we get this separation between what doctor, what a PA, what a nurse practitioner. There's a strong, practical argument to say that we don't have coverage in under certain areas. Let's just make them equivalent in certain
Right, and that doesn't necessarily apply to specialty care, which I think is important. And then I think if we all have in mind, it's the safety of the patient and the safety of all of us and our colleagues, I think we can get to a mutual understanding on what needs to be done.
But I do think that as supervising physicians, we have a responsibility to help impart continued education for these groups so that they can come up to a place where they are taking good care of their patients and being helpful to us. And if they are seeing patients without direct supervision, that we have known that this person specifically is able to do that, and that there are parameters set so that they know when to ask for help. And I do think there are cases where that is appropriate, but I think it is on us as supervising physicians, along with the APP leadership, to kind of create that framework.
Good. So we have another question back here.
Hi there. Thank you for a great presentation. From a comparative perspective, don't you think should it be fair to compare PAs to residents? Because if you compare those who just graduated, they're kind of equivalent to those new residents that you have on the floor. However, most of the study that you see, they're being compared to attendings who have tons of experience, and now you have newly fresh graduated APPs, and you're comparing them to the attendings. And I think from a comparative perspective, it's not fair because there's a difference between a resident and an attending. So I just wanted to know your thoughts about these comparisons.
So I think Tala is probably the best person to comment on this, but I would say, this is the point we're trying to make, is that PAs, and especially early on in their career, as well as NPs, are not independent practitioners. And just like we supervise residents, we need to continue our supervision, especially in our specialty.
And I think I agree with you in terms of if you look at clinical hours, it still falls short of a day one intern. But the problem is that the training and the advocacy groups for both PAs and NPs sort of bill this as they're ready to hit the ground running on day one. This is supposed to be a training program that enables people to really start practicing immediately without specialty training or requirement for specialty training. So I think the concern is there are programs, many hospitals out there that do a week of orientation, a couple shifts of orientation, and then put PAs and NPs out there practicing independently, which is why I agree with you. They should not be compared and put up in a practice environment functioning as an attending, but unfortunately that is what's happening. So when you look at the numbers in terms of education and clinical contact hours, and that's not everything, you have to sort of think about, in terms of education, PA schools do have a requirement for an emergency medicine rotation, the length of which is variable, where NP programs, FNP programs do not and often cannot have EM rotations. You have to take that into account when you're looking at years of residency. That 13,000 hours, 8,000 of that is emergency medicine specific by the time someone is done with year 3 of residency. So yes, it should be a new PA or NP. What we're advocating is that they we have a supervisory role similar to, say, an intern coming out, and then that competency-based assessments happen to see where they are as they continue along.
I will say also, though, that the research is difficult because a resident is always supervised by an attending. So you're comparing a resident attending unit with an independent PA or NP, and that is a hard comparison. So you're still kind of when you compare to a resident, you're still effectively comparing to the attending because the attending is always paired with the resident. So just in terms of getting that data, it's very hard to do. And that, I think, has been a lot of the challenge in getting research in this area, is kind of teasing out who's responsible for what.
Okay, I'm coming with the microphone. Hold on.
My question is, how do we make them more responsible for their training? It seems sort of disproportionate that they just get to half-train people, and now it's our responsibility to then train them to do our jobs. Is there not a way to make them increase their hours of training from 600 to even 2,000, which I still think is not enough, which would make a big difference in their skill capability when they start on and all those sorts of things? Do we not have any way to lobby for that?
Not to my knowledge, I have to say.
So comment just to your right was don't hire them, but I think, to translate that into a different message is, if that's not somebody that you think is employable who can do a good job for your patients, then maybe putting pressure economically by not hiring is the way to go until things are reformed a bit.
I think that yeah, so I hear require experience. There are some, but I think the key is, at least in terms of the hiring process, to know, because there's such great variation out there in terms of what the EM experience is, what the clinical contact hours and experiences. Even, there is this EMP certification, but even within that, there's quite a bit of variation in terms of what EM hours exist and are required and what didactics exist. So really being knowledgeable about that, and then hiring people that are appropriate for your particular work setting.
Yeah, and just to piggyback onto that, I think if you are a medical director, you're in charge of hiring, make sure, if we have PAs, we frequently look for experience as a medic before they went to PA school. For our nurse practitioners, which we've actually hired very few of because we had concerns about their training, we've only hired people that had emergency nursing experience prior to completing their advanced degree. And we've had success with that, or medic experience, less likely for them to have that, but more likely that they've been a bedside nurse. We have had no success with people who have done the direct entry programs, to the point where we have decided as a group that we will no longer hire them when they go directly through without bedside experience.
But I will say that even people who have experience working in the ED, you don't know what that experience was. If they weren't supervised at all, they came in with bad habits and left with bad habits.
Yeah.
And you don't know. So I do think it's our responsibility, regardless, to be supervising very closely, at least until we have been able to assess the competency of that person. So in my shop, every patient is seen by an attending as well, and they work side by side with the residents in a similar model, and it works very efficiently for us. But it also means that I know the ability of every PA and NP in my group, and I have almost 70, and I know their abilities very well, and I know there are a good number of them that I would totally trust to work independently, who've been with us for 8 or 9 years, but there are others who I wouldn't, and so you have to be able to make that individual assessment.
Yeah. And I think just our answers now are showing you the huge variability you have, so this is really another advertisement for really strict supervision, because you want to know every single person and what their capability is and what their training has been up until that point. And that's really our duty as medical directors. Andrew?
I just moved to North Carolina where there were all been certified nurse practitioners for independent practice. They will ultimately win that. That's going to happen. I think it's going to happen in most states. It's going to happen. Because I think the practical argument, the non-specialized coverage in rural communities has just went out on there isn't enough coming up. Having said that, in healthcare there is a drive towards kind of consolidation of control of networks. In other words, you've taken over a third of the state. UNC having a third, Charlotte having the other down there, and our state is basically 2 general ones, PA only departments. They can set their own qualifications for who can do what, and they can actually dictate regardless of what is being said.
Right, because they have autonomous boards.
And I think that's where you have to go, because you're not going to win it unless.
Right.
And like I said, that's what I think is going to happen.
Yeah, and by the way, these battles, and by the way, these battles are not just in emergency medicine. Right now, in Connecticut, we had a bill that went up that I was actually unaware of until a psychiatry colleague of mine said they want psychologists to be able to prescribe medications, and mostly for psychological reasons, but it wasn't actually restricted in the bill. And that was not even publicized. That almost sneaked through until I think many people were made aware of it and called their legislators and said, no way, these are people without any pharmacologic training. Why would you give them the right for prescriptive authority? So I think this is the battles going on in every state on multiple fronts, and we're not even aware of it because we're so busy.
I will just close by saying, though, that I think these groups are a vital part of the care that we impart, and they are incredibly helpful and wonderful and a part of our family and a part of the care that we give, and can be an incredible benefit to the care that we give if done correctly.
So I think we have a new group coming in that needs to get on, but we can take questions offline or by email. Our emails are up here if anybody wants to write them down. Thank you.